So yes, I am Beales, this is Mitchell, and this is Slats. We did have a break there. Number 5 at the moment, which is the stage of the condition. This is our warning slide where we are talking about this one element being the stage, but very important to remember that all the elements are intertwined and connected, and talking about them is a little artificial, but very important to remember they all sync together. Our quote for the day: the transition was difficult. It's hard to stop something that you've enjoyed, and that has been very rewarding. This is from Kareem Abdul-Jabbar, and really the key word around there is the transition, which is what we're talking about in relation to the stage. Yep, happy with that?
I'm happy with that.
Helen?
Yes, happy.
Yeah, good. So this is a figure again from the app, which you can get at the Apple Store and the Google Play Store.
Correct.
I've learned something. So yeah, look, we have this traditional kind of I can never say this word. Non-culture.
Nomenclature.
Thank you. Around acute, subacute, recurrent, and then chronic or persistent. So, I mean, that's clearly useful. Do you want to just talk about that briefly as a concept?
I think in terms of musculoskeletal pain and screening, it is important because critically for that acute presentation, you're going to want to make sense of that. In particular around red flags and needing to make sure that before proceeding you're clear on any serious conditions that you might want to screen out.
Yeah.
That's one thing. Probably the next thing is the type of management will be influenced by whether it's acute or not.
Yep.
And it's important to reflect the evidence-based approach to guidelines for acute conditions. For example, Ottawa rule for ankle pain, quite different from someone that comes in with a recurrent ankle sprain or persistent ankle pain. And I think one of the other considerations is it's an opportunity to really inform care well upstream and make sense of what's normal in advance of the clinical trajectory. And that includes things like understanding sensitisation and mechanical, non-mechanical.
What do you mean by upstream?
That means informing decision making based on an understanding of the pathophysiology, the actual condition-specific information which might be critical. For example, early presentation of rheumatoid arthritis might be really important to understand that clinical pattern and recognise that early recognition and on referral for biologics or assessment would be important.
A couple of things that come to mind for me. Traditionally in my initial physio training we learnt these stages, and acute was that, it varied from what the definition was, but it might be in those first few hours or days we called acute, and then there was this subacute phase that went somewhere for around 6 weeks, and then magically you leaped to 3 months and then suddenly you're in this chronic disorder. A few things that have evolved since then. One is we talk about being clearer around, even in the acute phase, what's actually been the mechanism or the starting onset for someone's symptom presentation. So the 3 main things, and this comes up elsewhere as well, but have they had a specific incident or trauma? Because arguably that's where, to my mind at least, the original training around acute was relevant, because someone would say, I've sprained my ankle like you mentioned, and then the Ottawa rules come in there around is there need for further investigation or radiology. But around that injury, there's arguably tissue trauma and a healing response to that. So then there's acute management around an actual tissue injury. The second one is there a mechanical or sort of physical overload approach is how we used to think about that. So has someone done an increased amount of physical activity, volume or repetition that's caused the onset of symptoms, which arguably may also be associated with some acute tissue response or tissue pathology. But you'll have someone presenting with acute pain where it's insidious onset. So there's been neither of the first two, and then suddenly the definition of acute changes, doesn't it?
It does, and I think that's where it's helpful just to remember you still need a really good working knowledge of pathophysiology there.
Yeah.
So there are limitations in that temporal classification, and I think we can talk about those as a sort of separate point. But if you've got someone with insidious onset of pain and no triggering event, it's also really important to understand what good screening for that looks like.
Yeah.
So it still could be secondary to a viral arthritis, for example. It could be an early onset polymyalgia rheumatica, etc. So thinking about why that's started and understanding the time frame there remains important to guiding clinical pathways, but it shouldn't be the only thing on which you base your assessment.
Yeah, we've just talked a little bit earlier in the diagnosis section around listening to the story and considering red flags and red flag disorders early on. And obviously if someone, as you say, has that insidious onset, arguably you have to think differently. The first bit is there other specific diagnoses coming in? But I don't know, Darren, if you can think of examples of patients in the past that you've seen that are presenting with acute pain, but there's really no concerning underlying pathology and insidious onset, where maybe your management of how you used to approach that differs compared to now?
Well, no, I don't have you put me on the spot there. I don't have a good answer for you there. I guess my mind was wandering to another thing which might be related in a little way, and it's the kind of pre-injury status of the person. And we've talked about some of those issues around the mental health status of the person, the general health status of the person, other comorbidities, obesity perhaps, all factors that are pre-existing but could then influence what the experience of that injury very quickly and then influence the course of it. So that doesn't really answer your question.
No, it doesn't. But it's a relevant point. Yeah.
I mean, that's where the framework becomes important when you operationalise it, because you can't look at one single factor alone. So suddenly all these other factors are becoming important. And I mean, again, if you think of sudden onset low back pain with no inciting event, someone young and otherwise healthy, and perhaps they're recreational drug user, then they might be at risk of a osteomyelitis. So still holding that information is important. But in the absence of screening all those things, or having screened all those things and there's no clear identifiable cause, then you're thinking of things, for example, like fibromyalgia, would you?
Yeah, potentially. There could be other disorders like that involved, or the other one that I think Darren's broadly talking about, we use that term if the system's pre-sensitised, and the system may be pre-sensitised by a disorder such as fibromyalgia. Or, I mean, an old example I use is how come a bricklayer does the same job day in, day out, and suddenly they get the onset of symptoms on a day of bricklaying, and we blame the physical component of the work. But if we look back across those different domains, is there sleep or general health or other factors that pre-sensitise the system? So they present with an acute onset of pain, but there's really not a tissue injury or trauma associated with that.
But it is human nature that I've got pain, there must have been something that I did to cause this pain.
Yeah, and I mean the easier ones are where there is an identifiable trigger and you can do appropriate triage. And where there isn't, it's mandated upon us, particularly if you first contact practitioners, to do your best job at understanding what it isn't, not just what it is. And that's the first no harm principle. So, that remains important.
You've got to be careful. I mean, the person will say, I hurt my back lifting a box, but then actually you discover later they lifted that 2 days before. So,
and that's a common one. I did some research on nurses with back pain, and of those 200 nurses, nearly all of them attributed back pain to a physically inciting event. But if you asked them specifically, did you have pain at the time, more than half of them said no. But I felt it at the end of the day or the next day, and then I thought back to what caused it. So as a society and also healthcare practitioners, I think we're trained into trying to find the physical cause, which might be there but may not.
So this is where the reasoning and contemporary evidence is really critical for the framework. So what you're doing is underpinning a problem-solving approach, sound clinical reasoning that balances support and negate evidence to help you move through the various domains and filter that information to basically at the end of it decide on balance what it isn't and what it is. So
Yeah.
not relying or weighting one domain too heavily.
Yeah.
I'm really glad we recorded that because it was great. Can you say it again? Exactly the same.
So
We've got it.
on that concept, I think we all agree that the different stages are important. So if someone's got an acute pain and they've got an acute tissue injury, we need to consider management around the healing timeframes of tissues, and there's other factors that we talk about later on that contribute to those. So what do we say if someone says, right, it's beyond that acute phase and it's subacute? Like, what does that mean, or what bearing does that have on our management?
And I think even just to add to that, which was one of the questions we had, is like what the transition from so-called acute pain to chronic, which is in that phase.
Yeah.
What do we think about the transition?
Look, it's a tricky question. I'm not a huge fan of the classification of chronic, so if we start there,
Yeah.
and the reason is because you get to day 90 and you're classified as subacute,
Yeah.
and day 91 you're suddenly chronic.
Yeah.
So I think that's currently an international sort of consensus, but knowing increasingly what we do about pain and the key risk factors for transition, rather than viewing it through a purely temporal lens, what's helpful is to think, does this make sense within the time frames of a tissue based injury and healing time frame, and what are the early factors that might suggest this is going down an unhelpful trajectory.
Yeah.
And we've got good tools to screen for those now.
Yeah.
And of course on refer, if there's something we've missed or it should see someone else early, that's important.
Yeah. I think on that, as a clinician, there's that alternate definition of chronic being beyond the expected
Tissue
healing time, which becomes really helpful because it may be 4 months, 6 months where tissue healing may take that long. You take someone with another health comorbidity such as diabetes, and that healing stage extends out and it's just going to be longer. So just because you say they've hit 90 days, that doesn't make this a chronic persistent disorder that we manage differently necessarily. It's okay, you're still in this tissue recovery phase in this instance, so that's, I guess, an example of it should take longer to get to that point. And I think, like you mentioned there, in the insidious onset or absence of tissue injury, it doesn't wait to 90 days for there to be higher risk of this to hit a
I think
poorer
that's the
trajectory.
critical point,
Yeah.
because of course conditions like fibromyalgia, irritable bowel syndrome are really difficult in the sense that there's no single inciting event that can be identified,
Yeah.
and that emerges, and that emergence is sort of announcing, you know, the start of something that's likely to be at least in the current understanding of the conditions, it's likely to be a long-term condition. I think, chronic is useful to some extent, but we shouldn't be constrained by viewing how we manage things purely by that temporal framework.
And the other part around that I find clinically helpful is, even if it's a very mechanical musculoskeletal presentation that someone presents, let's say someone with neck-arm pain that does office-based duties, but they've described this insidious onset, then we have to think about that. We haven't had a tissue injury, and traditional management of that might be, well, you need to go home and rest for a period to allow this to recover, but there's no tissue injury that needs to heal. And it may be for this person, they've done more office work because there's time deadlines or things are busier, so they've upped their hours. So the last thing they should be doing is resting more. If we hear that full story and understand that you've got acute pain but there's no tissue pathology, so one of the drivers in some instances might be underactivity, so your management early on is to do more walking or get more physical active, for example.
Tendinopathies would be a really good example there.
Yeah. So I think the broad definitions are important, but as you've said, understanding from that broader perspective and fitting the person's individual circumstances to
Yeah,
that.
and then recognisable chronic conditions that you know are going to need long-term management and fall under the banner of musculoskeletal, like the arthritis, rheumatoid arthritis, inflammatory arthritis more broadly. Those sort of conditions are important.
All right, question to both of you. The patient comes in with a new episode of back pain, short form Orebro, score 67 out of 100. That would put them in a high risk category for delayed recovery over 12 months in terms of return to work. How do you convey that risk to the person? Do you? You know, there could be negativities in telling someone that they're at high risk. How do you manage that? Go with you first, Helen.
Sure. Thanks for that, Craig.
That's all right.
Look, I'd probably look at the items that are driving the score would be my first take. And I'd take a deep breath and just for the first 2 weeks not let that drive too many decisions. Again, given the framework is trying to help you balance information, problem solve and understand the whole picture, it might be that I've logged that, I understand the drivers, and some of those might be immediately modifiable. So if possible, I might pick those off, and if it's an easy address, do it then and there. Reassure the person. And I guess the other thing is, how predictive is that in the first 2 weeks anyway?
Bit of science there. Well, I don't know the answer to that, but I do know that in a study that looked at the start back screening questionnaire a week apart, 30% changed their classification. So.
Yeah. And I think at the end of the day, that's not a perfect tool, it's a screening tool. And again, you're trying to triangulate that data with your other clinical findings and the evidence to sort of squeeze it through that evidence filter.
And all the recommendations around screening tools are there. Screening tools to supplement clinical reasoning. Tim?
Just to perhaps add a little bit to what Helen's saying there around, let's say you've used the short form Orebro and there's individual items that are high, the SFO.
Those in the know.
Yeah, I don't like acronyms. But let's say a couple of individual items were high, you can use that early in the conversation to say, look, from your story, in one example, there's been no trauma, there's not a clear increase in physical activity or overload, but these symptoms have come on, and we've mentioned a little bit about that concept of presensitizing. The questionnaire can become helpful there. I can see your sleep's not been any good. Is that an ongoing issue? Because we know that makes the system more sensitive and can amplify your pain. So sometimes early on, if the person gets an understanding, that I think is really relevant to me, you've got a focus of management along with treating perhaps the local condition to really help calm down one of the drivers of it.
That's pretty cool, because what you're doing there is picking off that clinical experimental piece of information and targeting that. Makes a lot of sense. And the other thing is, for the person with you at that point in time, contextualizing it so they know what you're experiencing at this point is a normal response to an abnormal situation. And I say that understanding that there's caveats, sometimes it's maybe more extreme than others.
Sure, and we've talked a little bit already around getting the individual's perspective and engaging with them in that dialogue around understanding the story. And if they're telling you these problems and you're just reflecting them back, that can really add to that clarity around them seeing, there's more than just the local issue here, there's these other factors that are definitely relevant.
Yeah, and validating what they're, rather than packing in on that score being, the key bit of information, it's just, I hear you, I see you, I believe you, let's go from there.
Yeah.
Excellent. I'm pretty happy that I understand everything about this element of the framework now, but any closing comments from you, Tim?
One thing around, we haven't really talked about recurrent, and where that for me is relevant as a simple example, if someone comes in with stick with neck arm pain, and let's say we do some management of that and that resolves quite quickly, person's back to function, away they go, great. If that person's come back a second or a third time with repeat episodes, so recurrent episodes of this, then that at least gives us pause to go, hang on, we can treat the symptoms or sort out this initial episode, but what are the bigger drivers of that? Yeah. So I think that just, again, brings the framework into utility of going, right, we can deal with that as a one-off, but can we step back and help this person sort this out as a more longer term approach.
Yeah.
That's a really good point, because
Yeah.
it's about the context, isn't it?
Yeah.
And how important is context to driving some of these conditions.
Anything else from you, Helen?
I hope the actual temporal cups change.
You working on that?
Behind the scenes.
Yeah. Great. I look forward to hearing about that.
Okay.
Okay, so we have a website. It's musculoskeletalframework.net. You been there, Helen?
I indeed have.
Were
Snooping
you
around.
There's some great resources there. Go and check it out.
Yeah, there's links on that website to information such as these videos, but other resources as well that are
Free
useful.
slides.
Yeah, there's
Free
free
slides.
slides for people that want to share information or knowledge around this.
I think that was one of the critical things from the framework when it was derived. It was about putting it out there for sharing.
Yeah.
We know it hasn't been fully road tested in the evidence sense, but importantly it really bridges the complexity that's challenging for understanding clinical presentations and making sense of them.
Great.
Good. Thanks,
Okay.
lads.
Righto, no problem.
All right. We'll see you next time.
Cheers.